This morning we have Dr. Hooman discussing fluids and sepsis. Dr. Poor received his medical degree from Columbia, where he also pursued his training in internal medicine and pulmonary and critical care. He has been at Mount Sinai since 2013, holding dual appointments in the Division of Pulmonary and Cardiology as Assistant Professor of Medicine. He is the Director of the Pulmonary Vascular Disease Institute of Mount Sinai-National Respiratory Institute, as well as the founder of the multidisciplinary pulmonary embolism response team at Mount Sinai. Dr. Poor serves as the Assistant Program Director for the Pulmonary Critical Care Fellowship. Please join me in welcoming Dr. Poor.
Thank you very much, Katie, and thank you all for coming. So today I'm going to present a slightly different take on the role of fluids in sepsis. I have no financial disclosures. So we're going to start with a case, very common case that you probably see. 83-year-old man with diabetes presents to the emergency department with altered mental status. His initial vital signs, he's febrile, he's hypotensive with a systolic blood pressure of 50, tachycardic, he's somnolent, very difficult to arouse, and his initial lactate is elevated, 7.2. Cultures are drawn, antibiotics are administered, and he gets 6 liters of normal saline. He's transferred to the MICU. So in the MICU, he's still hypotensive, 80s over 30s, tachycardic, but he's saturating 99% on 2 liters. He's breathing comfortably, he looks okay. His lungs are clear, his extremities are warm and well perfused, and he has no edema. Chest x-ray is clear. A repeat lactate now is still elevated, 4.2. And so I asked the question, should you administer more fluid to this patient? He's still hypotensive with an elevated lactate. He's received 6 liters and his lungs are clear. So the way that I was trained, and the conventional wisdom really has been that you have to give lots of fluid in septic shock. And that if you think you've given too much fluid, you're probably wrong, and that you should give more. And that the only potential harm is pulmonary edema. And if the patient gets intubated, that's okay, because large volumes of fluid are necessary in sepsis and septic shock. However, there's been a slew of recent trials, recent studies that have demonstrated an increased mortality, an association between increased fluid administration and increased mortality. One could reconcile these associations by noting that, you know what, correlation does not imply causation. It's not that increased large volume fluid administration results in increased mortality. It's merely that those who are more sick require more fluid, and those who are more sick are, have higher mortality. And so this belief that large volume fluid administration is paramount in the treatment of sepsis and septic shock has kind of been firmly entrenched in the medical community. And this is a quote from Rinaldo Bellomo. He's a principal investigator of the ARISE trial, one of the recent early goal-directed therapy trials, and a very prolific critical care researcher. And he notes that the need for early, rapid, and substantial fluid resuscitation in septic patients has long been an article of faith in the intensive care community, a tribal totem that is taboo to question. And so during this talk, I'm going to question this article of faith. I'm going to save you the suspense and show you my conclusion slide. And I'm going to argue that, in fact, large volume administration of fluid for patients with sepsis and septic shock is actually harmful, and that there is, with large volumes of fluid administration, increased mortality. And so as I look out here, this is the reaction that I see. But I would like to make one very early clarification, and that is I do not consider the one-time administration of 30 cc's per kg in sepsis as large volume as mandated by CMS. Okay? We are not talking about 2 liters of fluid. We're talking about 8 liters of fluid, 15 liters of fluid, 20 liters of fluid. Okay? Not 2 liters of fluid. Okay? So early clarification. I can move on. Thank you, Dr. Archer. So during this talk, I am going to specifically define the hemodynamic profiles of the general forms of shock. I'm going to describe the mechanism by which fluid administration actually improves organ perfusion. I'm going to review the concepts of oxygen delivery and lactic acidosis. And this will provide the framework and the foundation to be able to discuss the data for fluid administration in sepsis. So a quick definition. Sepsis is the life-threatening organ dysfunction caused by dysregulated host response to an infection. And as I start pretty much every talk, I always go to Ohm's law, and the fellows are laughing and rolling their eyes. But this describes a circuit, an electrical circuit, where the voltage difference across a resistor is equal to the current times the resistance. And we can model the systemic circulation in the same way. Specifically, instead of a voltage difference, we have a pressure difference. Instead of a current of electrons, we have a current of blood, which is the cardiac output. And the resistance here is the systemic vascular resistance. The pressure difference that we're looking at is the mean arterial pressure here, the arterial pressure, and the downstream pressure is the right atrial pressure here. When we rearrange the equation, we now have an equation for the map. And as we'll be talking about hypotension, you're never going to have a massively negative right atrial pressure. So for the sake of discussion, we can say that the map is essentially equal to the cardiac output times the systemic vascular resistance. Which brings me to my first take-home point. And that is that hypotension is caused by either a low cardiac output or a low systemic vascular resistance, or a combination of the two. And so there are three major forms of shock: cardiogenic shock, hypovolemic shock, and vasodilatory shock. And vasodilatory shock is often called distributive shock as well. And there are three hemodynamic parameters that define these forms of shock: cardiac output, preload, and systemic vascular resistance. And in each form of shock, there is a primary disturbance, a resultant effect, and then a compensatory response. So the primary problem in cardiogenic shock is a decrease in cardiac output, which results in an increase in preload, and the compensatory response is an increase in systemic vascular resistance. The primary problem in hypovolemic shock is a decrease in preload, which results in a low cardiac output, and the compensatory response is an increase in systemic vascular resistance. The primary problem in vasodilatory shock is a decrease in systemic vascular resistance. The compensatory response is an increase in cardiac output. And whenever I give this diagram to trainees, I often put a question mark here, because I note that preload in vasodilatory shock is a 1-hour lecture. Turns out this is that 1-hour lecture, or like 45 minutes. So vasodilatory shock notably has many causes, and sepsis is probably the most important one. But it is important to appreciate that many other things cause vasodilatory shock. And so you walk into a patient's room and you say, all right, patient's in shock, they look unwell. Hooman said, just look at these hemodynamic parameters and all will be good. You're like, well, how do I do this? So let's start with the systemic vascular resistance. My heart failure attending during training always said that he liked to assess this by using his hand perfusometer. Put your hand on the extremities. Are they cold or are they warm? Because if they are cold, that is indicative of a high systemic vascular resistance. Constriction results to less blood flow to the skin of the extremities. Resistance is high. And you've heard the term cold and clammy. That's because catecholamines increase vascular resistance, and they also stimulate sweating. Warm extremities, on the other hand, are indicative of a low systemic vascular resistance. And essentially, more blood flow to the skin of the extremities, they feel warm. We often write on our physical exam, warm and well perfused. Maybe we should write warm and thus well perfused. A little bit more poetic. But it's important to note that the premise here is that it's not the core temperature, it's actually the perfusion of blood. And hypothermic blood will still feel warm to the touch if it's perfusing the extremities. Often we have CVVH patients in the ICU with profound vasodilatory shock who are hypothermic, and they still feel very, very warm. So moving on, we go to cardiac output. Cardiac output is equal to the heart rate times the stroke volume. And heart rate's obviously very easy to measure. You either take the pulse or you look at an EKG. However, stroke volume is a little more complex, and we can use the pulse pressure as a marker of it. And the pulse pressure is essentially the difference between the systolic and diastolic blood pressure. So if you imagine you start with a diastolic pressure, the heart pumps out a stroke volume, then that results in a systolic blood pressure. The larger that stroke volume, the larger the pulse pressure. So the question is, how does fluid actually increase perfusion? And a common analogy that is used is that it's like filling up a balloon. And you fill up, you administer fluid, it increases the volume of fluid in the arteries. This results in an increase in pressure, and ultimately that increase in pressure increases tissue perfusion. However, there are a couple problems with this analogy. The first being that if this were the case, every single time you give fluid to a patient, the pressure should increase. However, that's not the case. Most of the time it doesn't increase, and sometimes it actually decreases. And the other important aspect is that pressure does not actually equal perfusion. Pressure is merely a marker of perfusion, and it's not a very good marker of perfusion, particularly in vasodilatory shock. Pressure is merely force per unit area, and perfusion is the volume of blood flow per unit time that goes by. And so we can do a little thought experiment to demonstrate this. Imagine you have an organ here with a circulation, a tube filled with blood. However, there is no pump. And let's say that we can measure the pressure and flow here. So we measure the pressure. Let's say the pressure is 20. Okay, it's a tube filled with blood. But there's no flow. Okay, there's no pump. And we say, you know what, I want to increase the perfusion to this organ. Let's bolus a liter of fluid. So we bolus a liter of fluid, and there's more volume, and the pressure goes up. However, there's still no pump, and there's no increase in perfusion. And therefore, you can see this distinction between pressure and perfusion already. However, and this is kind of like filling up a balloon. Now imagine you have a pump. And in this pump, you have this flow that's going around, and we can measure again the pressure and the flow. Pressure, let's say, is 20, and there's 2 liters per minute of flow. And again, we say, I want to increase the perfusion. Let's bolus a liter of fluid. With this bolus of fluid, the heart pumps out more blood, 5 liters per minute, and that results in an increase in pressure. So now we have pressure and perfusion both increasing. And so the question is, what is the mechanism by which fluid administration results in the heart pumping out more blood? And that takes us back to the late 1900s, to the work of Otto Frank. And so he basically had a frog heart preparation where with a bunch of stopcocks and valves and manometers, he was able to increase the filling of the ventricle of this heart. And he measured pressures. And he noted that as he increased the filling of this ventricle, the diastolic pressures increased. But more importantly, as he filled the ventricles, the systolic pressures increased. The heart was squeezing harder. When you fill the heart more, it squeezes harder. Now, fast forward a couple years to the work of Frank-Starling. He took some dogs and did thoracotomies on them and ligated the IVC here and also the distal aorta and branches of the aortic arch. He kept the pulmonary and coronary circulations intact. And then he had this cannula in the aortic arch that diverted blood into this extracorporeal circuit and sat in this reservoir. And he had a valve. And this valve essentially was used to determine the amount of blood flow that went back to the heart. And what he found was when he opened this valve, there was an increase in cardiac output and an increase in right atrial pressure. And so someone decided to take this curve, where cardiac output increases and right atrial pressure increases, and simply flip the axes. So now you have right atrial pressure on the x-axis, and you have cardiac output on the y-axis. And this curve should look pretty familiar, particularly to first-year medical students. And this is the Frank-Starling law of the heart. Essentially, where you have central venous pressure and stroke volume. And during this talk, I'm going to use central venous pressure and right atrial pressure interchangeably. Where at the ascending portion of this curve, when you administer fluid, there is an increase in central venous pressure and also an increase in stroke volume, which means an increase in cardiac output. When you administer fluid at the flat portion of the curve, there is an increase in central venous pressure, but no increase in stroke volume. And so we call this portion here fluid responsive, and we call this portion here not fluid responsive. And so it's important to note that hypovolemia, low preload, causes a low cardiac output. You are essentially pumping out nothing, and that is the reason why hypovolemic patients are hypotensive. They have a low cardiac output. You have not one, but 2 ventricles. Okay, so these are Frank-Starling curves, essentially for the left and right ventricles in dogs. And the question is, which ventricle needs to be fluid responsive? Is it the right or the left? So we can do a couple thought experiments. Let's assume the right ventricle is responsive, but the left ventricle is not responsive. We administer fluid. The right ventricular preload increases. The right ventricle is preload responsive, so now the cardiac output goes up. That output results in increased filling of the LV. However, the LV is not fluid responsive, and there's no increase in LV cardiac output. If the RV pumps out more blood, and the LV does not pump out more blood, you now have accumulation of blood in between the RV and the LV, and that's called pulmonary edema. Now let's take the scenario when RV is not responsive, but the LV is fluid responsive. We administer fluid. The RV preload increases. However, because the RV is not fluid responsive, there is no increase in cardiac output, and you merely get systemic venous congestion. So if the RV and the LV are both fluid responsive, you administer fluid, RV preload goes up, it's responsive, so the cardiac output goes up, more filling to the LV is also responsive, you have an increase in LV cardiac output. So that brings me to the second take-home point, that fluid administration increases perfusion only if it results in an increase in cardiac output. and that both the RV and the LV must be fluid responsive for fluid administration to increase cardiac output. And so the way that I was trained was that CVP, the central venous pressure, predicts fluid responsiveness. And this makes complete sense. You have the CVP here in a stroke volume. You see low CVP, you should be fluid responsive. High CVP, you should not be fluid responsive, like very obvious. And in fact, that's what the Rivers trial used in early goal-directed therapy. A CVP less than 8 was to give fluid, and if not, to continue on. And I'll talk about the Rivers trial more, I promise. But clinically, does the central venous pressure actually predict fluid responsiveness? And this is a very well-known paper by Pulmonary, where it was a meta-analysis of 2 different types of trials. Those that evaluated CVP versus more complex invasive ways of blood volume, and those that evaluated CVP versus a change in stroke volume or cardiac output following a fluid challenge. Did the CVP predict whether the stroke volume or cardiac output would go up with the administration of fluid? And so with respect to CVP and blood volume, there were 5 trials. And what they noted was that there was an R value of 0.16. So that means an R value of 1 is a perfect correlation between CVP and blood volume, and an R value of 0 means 0 correlation between the two. And this is a graph from one of those trials where they have deficit or excess of blood volume, this is euvolemia, versus CVP. And you can see that the dots are all over the place. And if there were to be a correlation between CVP and blood volume, you should have those dots along this line here, where high CVP is associated with high volumes, low CVP is associated with low volumes. Now, there were 19 trials that evaluated CVP versus volume responsiveness. That is, measure the CVP, give fluid, see if the cardiac output goes up. Does the CVP predict whether that will happen or not? The area under the curve for these trials was 0.56. So an area under the curve of 1 means there is perfect discrimination when using CVP. An area under the curve of 0.5 means it's as good as a coin flip. So he has this kind of cheeky title here, a systemic review of the literature and the tale of 7 mares. And the reason he has this is because of all the trials that he found, there was only 1 trial that found a relationship between CVP and fluid responsiveness. And that was in 7 mares, horses, that underwent controlled hemorrhage. All the other trials were completely negative with respect to CVP predicting that. So how do we reconcile this? How do we say, the Starling curve exists and we have this curve. Why is it that CVP does not predict fluid responsiveness? That should be concerning to us. And to answer this, we have to go back to Starling's original experiment. And I made the point that this is the graph that he originally made, and someone then decided to flip the axes. And so often when we put something on the x-axis, we assume that it's the independent variable and that we change this. And as a result, we get changes in the dependent variable. And so when we increase the CVP, it is because we increase the CVP that there is an increase in cardiac output. And it turns out that's not exactly what was done. And if you look at the experiment, the independent variable was really opening the valve. When you open the valve, more blood comes back to the heart, and that results in an increase in central venous pressure. When you open the valve, more blood comes back to the heart. That results in an increase in cardiac output. And so if you were to graph the percentage of the valve being open versus the right atrial pressure, you see it goes up. And when you open the valve more, the cardiac output also goes up. And so CVP really is not a marker of preload. And Starling himself, in a lecture in 1915, said that the law of the heart is thus the same as the law of muscular tissue generally, that the energy of contraction, however measured, is a function of the length of the muscle fiber, and that preload is technically the degree of cardiomyocyte stretch prior to contraction. And another way to look at this is, can one increase the CVP but actually decrease the preload? Because if you can increase the CVP but decrease the preload, clearly CVP is not a marker of preload. And the answer is yes. Just squeeze the heart. So if you squeeze the heart, you get a rise in central venous pressure. And if you squeeze the heart, there's less stretch, and the preload actually goes down. And you're like, well, I'm not a cardiac surgeon. I don't plan on squeezing anybody's heart. But it turns out patients in the setting of certain pathologies and iatrogenic complications squeeze their own hearts. And if you're on positive pressure ventilation, that increased pressure in the thorax squeezes the heart. Hyperinflation from asthma and COPD, that air results in squeezing in the heart. Pneumothorax squeezes the heart. Fluid around the lungs in the setting of large pleural effusions, or fluid in the pericardial effusion, squeezes the heart. And in my mind, the most important, decreased ventricular compliance. The heart is basically squeezing itself, and it's stiff. And this is particularly important in the setting of endogenous and exogenous catecholamines. The heart is actually very stiff. So take-home point number 3 is that CVP is not a useful marker of fluid responsiveness. And unfortunately, I don't have time for this, but neither is IVC respiratory variation as measured by ultrasound. If you're interested, you can ask me later. Obviously, no talk about sepsis would be complete without talking about the Rivers trial. And this is the early goal-directed therapy trial published in the New England Journal in 2001. It was a single-center study in Detroit where they took 263 patients with severe sepsis or septic shock. And they were randomized to 6 hours of early goal-directed therapy versus standard therapy. And early goal-directed therapy was placing a central line, measuring the CVP, and administering fluid if it was less than 8. Vasopressors to achieve a MAP greater than 65. And measuring the central venous saturation and administering blood and or inotropes to achieve a central venous saturation greater than 70. And this trial showed a in-hospital mortality reduction, standard therapy of 46.5% versus 30.5% in the early goal-directed therapy group. And this ushered in a new enthusiasm for the early targeting of hemodynamic variables in early goal-directed therapy. And the interpretation of this study had been that the Rivers trial was a study of early goal-directed therapy versus non-protocolized usual care. And this is what I thought for the longest time. That the Rivers trial demonstrated the importance of CVP-guided fluid therapy, and that this was a study of lots of fluid versus very little fluid. And it turns out these statements aren't actually true, and I was quite shocked when I looked into this. It turns out the standard care actually had a protocol. And the protocol was exactly the same as the early goal-directed therapy protocol, with the exception of targeting that central venous saturation with blood transfusions and inotropes. So they had the goal of CVP 8 to 12, MAP greater than 65, and this urine output as well. And so this also indicates that if both groups are using CVP for their fluid management, then CVP-guided therapy should not be the reason why you can say there was a mortality benefit, because both groups used it. And so how much fluid was actually administered in these two groups? In the first 6 hours, the standard therapy group got 3.5 liters, and the early goal-directed therapy group got 5 liters. So to put that into context of a standard 70-kilogram patient, they received 50 cc's per kg in the 6 hours, and this is the standard therapy group. And this increase of 1.5 liters is there, but this is on top of a significant amount of fluid that's already being administered. And then you look at the 72 hours. They received the same amount of fluid. And you are reading that correctly. It's 13 liters of fluid in the first 72 hours. And you're also reading that the standard deviation is 7. So 2 standard deviations above the mean means that half the patients received anywhere between 13 and 27 liters of fluid. So this was not a trial of a little fluid versus a lot of fluid. This was a trial of a gargantuan amount of fluid versus a gargantuan amount of fluid. And so it's also important is why did the early goal-directed therapy group actually get more fluid? Because they both had CVP 8 to 12 as their goal. And so it's actually concerning that the control group didn't get as much fluid as they did, because that introduces confounding. Why didn't they get more fluid? Are there other things that happened as well that we don't know about that may have resulted in this mortality difference? So clearly this trial was extremely controversial and resulted in not 1, not 2, but 3 extremely large randomized controlled trials looking at early goal-directed therapy with targeting of the central venous saturation with blood transfusion and inotropes versus variations on usual care. And they showed no mortality benefit with this strategy. I do want to point out that the amount of fluid that was administered to both of these groups, the control and the therapy groups, was similar. So these were not fluid trials, okay? So what is this central venous saturation thing anyway, right? Everyone keeps talking about this. Well, first we have to go back to discussing what oxygen content actually is. And oxygen is found in 2 forms in the blood. The majority is found in the blood, 98%. I see some of my med students here. I gave this talk to them yesterday. I stole the slides from my own lecture. So 98% in the oxygen and 2% that's dissolved. And we can actually have the equation where this is the hemoglobin-bound oxygen, and this is the dissolved portion. And you can see that the dissolved portion is very small. And so for our intents and purposes, we can just say that the content is equal to merely the oxygen-bound, the hemoglobin-bound oxygen. And so tissues don't actually care about oxygen that's sitting in static blood. They care about oxygen that's being delivered to them. So we have to look at what is known as oxygen delivery. And that's equal to the content times the cardiac output, the oxygen being delivered to the tissues. And if we plug in the oxygen content equation, this is what we get for oxygen delivery. And this equation is extremely important because it helps us understand compensatory mechanisms that happen in disease. So take, for example, anemia. When a patient is anemic, their hemoglobin is obviously low. And as a compensatory response, because their oxygen delivery is low, they increase their cardiac output. Heart rate goes up, their contractility goes up, they hold on to more fluid, they have a flow murmur. Take, for example, athletes that train at altitude. They go to hypoxic conditions, they become hypoxemic, and therefore they ultimately have low oxygen delivery and then get secondary polycythemia. And if you're Lance Armstrong, you just kind of just give yourself EPO. So then we can look at the relationship between oxygen delivery and oxygen consumption. And if you deliver a ton of oxygen to the tissues, you, let's say, will consume this much oxygen. But as you deliver less and less and less and less, you will still consume the same amount of oxygen. You will merely extract a higher percentage of it, up until a point. And that point is when you start delivering enough oxygen and your oxygen consumption actually goes down. And bad stuff starts to happen at this point here. And so one way to look at the relationship between oxygen delivery and oxygen consumption is to basically measure what comes back from the tissues. And so a couple definitions. The central venous saturation is a venous saturation in the central vein, specifically the superior vena cava. And the mixed venous saturation is that which is measured in the pulmonary artery. It's a mix of the SVC and the IVC and all the blood that comes back. And the central venous saturation tracks the mixed venous, so for all intents and purposes, we use that because we don't need a PA catheter. So let's assume that the body is delivering 10 units of oxygen per unit time. The body consumes 3, and that which comes back is 7, so 70%. Now we assume that we deliver less oxygen, 5 units of oxygen per unit time. The body still consumes 3, and less comes back, 40%. Let's say we double the amount of oxygen that's being delivered, 20. We still consume the same amount, and we have a higher percentage that comes back. So you can see that we can use the venous saturation and that which comes back as a way to gauge the oxygen delivery that's going on. And so this is our oxygen delivery equation, and we note that cardiac output is here. So those who have cardiogenic or hypovolemic shock will have low venous saturations. Those who have vasodilatory shock, because of that increased cardiac output, will have high venous saturations. But this begs the question, I understand why someone with cardiogenic or hypovolemic shock is in shock. They have low cardiac output, therefore they have low oxygen delivery. Why in the world is someone in vasodilatory shock who has an increase in oxygen delivery in shock? And so to answer this question, I made a silly diagram of a 2-organ species, which consists of brain and kneecaps. And so there's a cardiac output that provides blood to the brain and the kneecaps. Let's say there's 6 liters per minute, and the brain gets 4, and the kneecaps get 2. And so let's say that for some reason there's some bleeding, and that there's a decrease in blood volume, decrease in preload, decrease in cardiac output. 6 liters now goes down to 5, which then means the brain and kneecaps get less blood. 4 goes down to 3.3, kneecaps go down to 1.7. But the brain wants 4 liters per minute to function. So as a compensatory response, the kneecaps will vasoconstrict, less blood will go here, more blood will go to the brain, and therefore the brain is happy. And the kneecaps feel cold. And so this is the compensatory response that we see in a low cardiac output. It's increased systemic vascular resistance. Now, let's look at vasodilatory shock. Let's say that there is inappropriate vasodilation here, and now because of this vasodilation, there's more blood flow going through here, and this is at the expense of the blood going here. 3 liters plus 3 liters equals 6 liters. Brain, again, needs 4 liters per minute to function. And therefore, as a compensatory response, the cardiac output is increased. More blood flow goes through here, more blood flow goes out through here. The brain is happy, and the kneecaps feel warm and have bounding pulses. And as you can see, the compensatory response for a decrease in systemic vascular resistance is an increase in cardiac output. And it's important also to note that in the setting of profound vasodilatory shock, you may still, despite that increase in cardiac output, not achieve enough perfusion to those vital organs. And that's why you're actually in shock. And so take-home point 4 is that pure vasodilatory shock causes hypoperfusion from maldistribution of blood flow. And that's why the term distributive shock can be helpful. So the conventional wisdom has been that, while fluid administration might not always increase perfusion, it can never really decrease it. And so I'm going to kind of talk about cardiorenal syndrome. And to put this in the most technical terms possible, it's when the heart has something wrong with it and it results in the kidney not doing so well. And it's a complex set of mechanisms, and one mechanism that's often touted is that the heart is pumping out less blood, less cardiac output. It results in decreased perfusion to the kidneys, and then you get decreased renal function. So this was a trial that was published in JACC that wanted to look at specifically these hemodynamic parameters. So 145 patients with acute decompensated systolic heart failure, and they underwent medical therapy with the PA catheter. And they wanted to determine the hemodynamic parameter that best correlated with the risk of developing worsening renal function, which was defined as a creatinine increase of greater than 0.3. And the parameters that they looked at were systolic pressure, systolic blood pressure, the wedge pressure, which is the filling pressure of the left side, the central venous pressure, and the cardiac index, which is the cardiac output relative to your body surface area. And so what they found was that there was no correlation between the risk of developing worsening renal function and your systolic blood pressure. There was no correlation between the risk of worsening renal function and your wedge pressure. There was a very mild correlation between cardiac index and the risk of developing worsening renal function. And it's in patients who had higher cardiac index who had a increased risk of worsening renal function. But what was profoundly correlated was CVP. The higher your CVP, the higher your risk of developing worsening renal function. And so the question is this merely a correlation? Sicker people have higher CVPs and worse renal function? Or is this causative? Does this increase in CVP actually cause this? Turns out that we've known that increased venous pressure has caused renal dysfunction for over 80 years. And this is a study by Winton where they took the kidney of a dog and they cannulated the renal artery and they cannulated the renal vein. And they were able to manipulate the pressures of the artery and the vein. And they were able to measure blood flow through the kidney and also urine output. And so when they increased the venous pressure to 24, blood flow through the kidney dropped, so did urine output. And then when they brought it back to normal, blood flow resumed, and so did urine output. And this was similar to decreasing the arterial pressure. Blood flow dropped, and urine output also dropped, which resumed as soon as that was resolved. And so I can also describe this with one of my silly diagrams, where you have a kidney here, the arterial pressure, and the venous pressure, and the flow through the kidney, and the resistance. And we can model this with the V equals IR of Ohm's law. And specifically, the pressure difference divided by the resistance will equal the flow through the kidney. So let's assume now that we administer fluid. When we administer fluid, we increase the pressure in the veins. And if the heart is fluid responsive, this will increase the stroke volume, increase the cardiac output, and ultimately increase the arterial pressure, which will result in an increase in flow. And that is the mechanism by which a hypovolemic patient with prerenal AKI responds to fluid. It increases cardiac output, increases renal perfusion. Now, take the scenario where you give fluid, venous pressure goes up, however, the heart is not fluid responsive. The stroke volume does not increase, the cardiac output does not increase, and therefore the arterial pressure does not increase. And that therefore results in a decrease in flow. And so we need not just keep the kidneys here. We can put the liver here, and this can be an etiology for shock liver. We can put the bowel here, and this can result in bowel wall edema, ileus, and bacterial translocation. This is in fact what portal hypertension is. It's venous obstruction, venous congestion, causing many of these problems. We can put the brain here, cerebral edema, and encephalopathy. And so not only is there tissue congestion, but there's edema that happens because of that. And so everyone knows well the effects on the lungs. You have pulmonary and interstitial edema that impairs gas exchange. Patients are hypoxemic. The lungs become less compliant and more stiff, and it takes more force and effort to be able to fill them, which increases the work of breathing. But it turns out edema in all organs is bad. And so it impairs oxygen and metabolite diffusion, it distorts tissue architecture, impedes capillary blood flow, disturbs cell-cell interactions. And these effects are pronounced in organs that are encapsulated, organs like the liver and the kidney. Because when you increase interstitial volume, increase the volume of edema, that results in an increase in interstitial pressure. It cannot expand, which then results in a decrease in organ blood flow. And so I showed you this schematic before where the RV is not responsive, and you just merely get an increase in systemic venous congestion. However, in patients who have severe pulmonary hypertension and RV failure, that increase in RV preload is actually catastrophic. And that can result in worsening RV failure, decreased RV cardiac output, and hemodynamic collapse. And these are the patients that I see all the time in pulmonary hypertension and also pulmonary embolism. So the central tenet in sepsis has really been that we must increase oxygen delivery. And so it's great because we have the oxygen delivery equation. So let's increase oxygen delivery and see what happens. And we can start with hemoglobin. So when we start with hemoglobin, there's a trial that was recently published that took 1,000 patients with septic shock and who had a hemoglobin less than 9. And they randomized them to 2 different strategies. Transfuse if it's less than 7, transfuse if it's less than 9. And the primary outcome was death at 90 days. And so they achieved their transfusion goals. This is the 9 group, this is the 7 group. So there was a difference between the hemoglobins. However, there was no difference in mortality, completely the same. Okay, well maybe we should increase the cardiac output. And this is an important one because it's been shown that patients with sepsis who have an increase in cardiac output have better survivals. So perhaps if we increase the cardiac output with inotropes, we may achieve that survival benefit. And so this was the trial that was published in the New England Journal in 1994, 100 patients with critically ill admitted to the ICU. And they were randomized to 2 groups. Normal cardiac index group. So they received dobutamine only if their cardiac index was below 2.8. And the high cardiac index group. They received dobutamine only to achieve a cardiac index greater than 4.5. Now the upper limit of normal for a cardiac index is about 4. Turns out they had, and so, excuse me, they achieved that increase in cardiac index. So you can see in the dobutamine group, higher cardiac index, and because of that increased cardiac index, there was an increase in oxygen delivery. So we have one group where we've increased oxygen delivery, the other is a normal group. Turns out they had to stop the trial because it increased mortality. And so this is the treatment group, this is the control group. 54% in the treatment group, 34% in the control group. And there were, most of these patients had septic shock. Again, a higher percentage of patients dying in the treatment group. And interestingly, despite this increase in oxygen delivery, there was no increase in oxygen consumption. And so we deliver more oxygen, but the body wasn't using it. And so this is similar to my daughter when she doesn't want to eat. She's finicky, and I want her to eat, but if I deliver more food to her, she's not necessarily going to eat it. She's merely going to get it on her bib. So what if we did something nuts? What if we, instead of increasing oxygen delivery, decreased cardiac output by giving a beta blocker? And so this was a trial that took 77 patients with septic shock on high-dose norepinephrine who were tachycardic. And the dose of norepinephrine here was 0.39 mics per kilogram per minute. So for a 70-kilogram patient, that's 27 mics per minute of Levophed. So in our ICU, we often don't go above 20. So these are extremely sick patients. And they randomized them to getting esmolol, which is a short-acting drip of a beta blocker, to maintain a heart rate between 85 and 94 versus standard treatment. And so you can imagine my first reaction to this trial when I read this was, you've got to be kidding me. Like, are they truly going to give a beta blocker to reduce heart rate, reduce cardiac output, and reduce oxygen delivery to the most floridly septic patients that exist? And so they did, and their primary outcome was, maintaining a heart rate between 80 and 94, and they achieved that. And you're like, great, so you gave a beta blocker and the heart rate's less. Like, how in the world did this get into JAMA? It got into JAMA because it resulted in a massive mortality benefit. So in the esmolol group, mortality was 49% versus 81% in the control group. And this was both in univariate and adjusted survival models for covariates at baseline. So if we increase oxygen delivery by increasing the hemoglobin transfusion, there is no change in mortality. If we increase oxygen delivery by increasing the cardiac output with the use of dobutamine, mortality is increased. If we decrease oxygen delivery by decreasing cardiac output with the use of esmolol, mortality is decreased. So why is it that we think that the administration of fluid to increase cardiac output to increase oxygen delivery is necessarily beneficial? So I'm just going to shift gears a little bit and talk about lactate. And often the thought is that if lactate is elevated, it indicates hypoperfusion and that we must give fluid. And lactate, the molecule, has had a terrible reputation. It is viewed as this harmful substance that actually injures the organs, that the lactate itself causes acidemia, that an elevation of lactate is diagnostic of sepsis, and that an elevation of lactate in isolation is an indication to administer fluid. Now, these statements are not entirely correct. And we go back to our college biochemistry course. Glucose gets converted to pyruvate via glycolysis. And under aerobic conditions, where oxygen is present, you make a lot of ATP and carbon dioxide. Under anaerobic conditions, where there's no oxygen, you make not much ATP and lactate. The question is, where does the acidosis come from? And the common thought is that you develop lactic acid, which dissociates into the conjugate base and a proton. But it turns out this doesn't actually happen because we don't make lactic acid. We make lactate. And so where does the proton come from? Because this is a conjugate base. This is a carboxylate. Turns out the acid comes from alterations in ATP metabolism. So when you create ATP, ADP phosphate results in ATP. This is an acid-removing state. When you hydrolyze ATP, ATP it's actually an acid-producing state. So there's some kind of equilibrium here at kind of normal conditions where you're not acidemic or alkalemic. However, in the setting of anaerobic metabolism, you don't make much ATP. So this is kind of decreased by a lot, and you have a net acidemia that results. And so lactate is actually a very beneficial molecule. The lactate generation from pyruvate reduces acidemia. So this is a more complete chemical equation for glycolysis. Glucose gets converted to pyruvate and ATP. And it's notable that with glycolysis, you release protons. And with fermentation, which converts pyruvate to lactate with the very famous LDH, lactate dehydrogenase, this is an acid-removing state. So by undergoing fermentation, you are actually removing protons from the system to allow for more glycolysis to actually occur. Additionally, lactate generation releases NAD+, and this is a substrate for glycolysis. So in order to do more glycolysis, you need more NAD+, and this allows for that to happen. And finally, lactate serves as a metabolic fuel for the heart and the brain, and does so especially in times of stress. And so decreased oxygen delivery is a cause of lactate. And again, that's when you have decreased oxygen delivery such that you cannot consume oxygen anymore, and you must undergo anaerobic metabolism. But there are many, many other causes of increases of lactate. And none of these causes are actually indications for the administration of fluid. And within sepsis, there are many mechanisms by which lactate can be elevated. Tissue hypoxia from decreased oxygen delivery is probably a cause. However, mitochondrial dysfunction, where the mitochondria actually cannot use the oxygen, that results in lactic acidosis. And most importantly, I think, is adrenergic stimulation of glycolysis, where via the beta-2 receptor, both endogenous and exogenously administered catecholamines result in increased cyclic AMP, activation of the sodium-potassium pump, which results in increased ADP, and that stimulates glycolysis. When you stimulate glycolysis, you get more pyruvate. If you get more pyruvate, you get more lactate. And so we're often in the scenario where a patient has received a bunch of fluid, and certain markers have improved a little bit. Blood pressure got a little bit better, lactate got a little bit better, and we are excited. That's great news. But at the end of the day, the patient doesn't care about their levofed dose, and the patient doesn't care about their lactate. The patient just wants to go home and play with their kids. And so it's important to appreciate what lactate and blood pressure actually are. Because an increase in lactate and a low blood pressure are associated with increased mortality. If you administer fluid, you can reduce the lactate and increase the blood pressure in certain scenarios. But that does not necessarily mean that the administration of fluid will ultimately decrease mortality, because lactate and blood pressure are surrogate markers. And we've been burned numerous times before in the medical community when we chase after surrogate markers. And so what we really need are randomized trials. We need trials where we basically have one group where we say, don't give much fluid, and another trial where we say, give a significant amount of fluid, and find out who actually, it was a little distracting, I shouldn't have put that up there. No one listened to a word that I said right there. That's fine. And so we need these two different strategies. And while we don't have the perfect randomized controlled trial yet, we have a couple that hint at the fact that something may be going on. And the first is the FACT trial. This is a trial of 1,000 patients with ARDS, of which 70%, the cause of their ARDS was sepsis or pneumonia. And so ARDS is non-cardiogenic pulmonary edema. It's fluid in the lungs because of increased permeability, leaky capillaries. And it's defined by the P-DAF ratio less than 300, bilateral pulmonary infiltrates, and this pulmonary edema is not completely explained by left heart failure. And so this trial randomized the group to liberal versus conservative fluid strategy. And this was their protocol. Extremely complex and painful to go through, and I'm not going to. But in short, if the patients were hypotensive, they basically got fluid impressors. If they were not hypotensive, based on this stuff and based on their CVP and wedge pressure, one of these boxes was assigned, and they got either fluid or Lasix. So this really confusing thing. But ultimately, it resulted and a difference in the amount of fluid that was given to these patients. The liberal strategy had an increase of a net positive 7-liter fluid balance. The conservative strategy was basically net even. And there was no difference in mortality. However, in the conservative strategy, there was an increase in ventilator-free days. And that means that they were alive and off the ventilator longer. Increase in ICU-free days, which means they were out of the ICU and alive longer. And there was no increase in non-pulmonary organ failure. This wasn't like decreased perfusion. And so that's important, however, not really convincing. But one little gem here, I think, is this corner here. And these are patients who were not hypotensive and who had good circulation. And they had low venous pressures. And as you can see, they separated out the two groups, liberal and conservative. And this subgroup was actually recently analyzed. These were 169 patients without shock and an initial CVP of less than 8. And the liberal strategy stated that you had to achieve a CVP of 10 to 14, which meant this group got fluid, right? The conservative strategy had a goal CVP of less than 4, which meant this group, if it was less than 4, you gave them nothing. If it was 4 to 8, you diuresed them. So now we have a randomized trial. It's a subgroup, randomized trial, where we give some people fluid, and we don't give fluid / diurese the other group. Their cumulative fluid balance was very similar, 0 and 7. But it turns out there is a huge mortality benefit in the conservative arm, where not giving fluid resulted in a decrease of mortality, 36% versus 17%. So finally, I'm going to talk about the FEAST trial. This was 3,000 children with severe febrile illness in under-resourced countries in Africa, aged 60 days to 12 years, and the median age was 2 years. And they had to have clinical evidence of impaired peripheral perfusion without severe hypotension. Exclusion criteria include severe malnutrition, gastroenteritis, so no, true volume loss, non-infectious causes of shock, and contraindication to volume expansion. And they were randomized 1:1:1 to getting 20 cc's per kg of normal saline, 20 cc's per kg of albumin, or nothing. And it turns out, and the primary endpoint was 48-hour mortality. They had to stop this trial early. And they stopped this trial early because the administration of fluid, both with saline and with albumin, resulted in an increase in mortality, 10.5% versus 7%. And this mortality difference persisted at 4 weeks. Now, there are obviously limitations to this study. It's a pediatric population. We're treating adults. However, the pediatric intensivist also thinks similarly. We must give lots of fluid. Many patients had malaria, but when you look at the subgroup analysis of patients who didn't, this effect was still the same. And there's insufficient information about why these patients died. And most importantly, this is a resource-limited setting. They didn't have ventilators, vasopressors, or renal replacement therapy. So you can't necessarily say in this setting giving fluid will be harmful because we have ventilators. That may actually counteract and be beneficial. So how do I think we should practice for now? The gold standard in my mind for fluid responsiveness is to give the fluid, okay, and to see what happens. All of these markers are actually not helpful beforehand. And if you have hypotension or an increase in lactate and you have a reasonable suspicion for sepsis, you should give some fluid early. And for right now, I think 30 cc's per kg is appropriate. There is rationale for this. Patients don't become septic like that. They often are sick and they have decreased intake. They're sick for a couple days and they get worse and they don't take in as much. They'll have increased external losses because they're febrile for 3 days. They may have some diarrhea. They will have some leakage into the interstitial space. And importantly, they have vasodilation, specifically venodilation. So the veins hold most of the blood. If this dilates, more of it will pool there. Less will come back to the heart. The preload will actually be reduced. Use this as an opportunity when you give this fluid to see if things get better. Are there markers of perfusion that have improved? If there are no markers of perfusion that have improved, stop giving fluid. If yes, then I kind of cop out and give this, weigh the risks and benefits of further fluid administration. This is where I think it gets really interesting. But you say they're still kind of hypotensive. What should we do? You should start vasopressors. And again, remember that the primary problem in vasodilatory shock is a drop in systemic vascular resistance. They're vasodilated, so why not give a medication that vasoconstricts? And it's important to note that you should not view vasopressors as a medication to increase the blood pressure, okay? We use blood pressure as the target, but it is not a medication to increase the blood pressure. Again, pressure is not a good marker of perfusion. And you can view this situation like this. You have an organ with blood flow. If this organ is now hypoperfused and I say, I want to increase the perfusion to this organ, I am going to administer a vasopressor. When you administer the vasopressor, you get vasoconstriction here. which then results in an increase in pressure here, but a decrease in flow to the organ. This is basically like me putting my finger over a hose. The pressure behind my finger will go up, however, the flow out of the hose will go down. So why in the world would you give a vasopressor in this scenario? And we go back to my silly diagram of the two organ species, who's in vasodilatory shock. In this case, we have 3 liters going here, 3 liters here with vasodilation. The brain needs 4 liters per minute. And so when you administer a vasopressor, you preferentially vasoconstrict this area. Less blood goes down here. More blood goes up here. The brain is happy. So, in summary, remember this equation, that the mean arterial pressure is equal to the cardiac output times the systemic vascular resistance. Hypotension occurs because one or both of these markers is low. Pressure is not perfusion. Pressure is not a very good marker of perfusion, and particularly in vasodilatory shock, this is true. Fluid administration increases perfusion only if it increases cardiac output. That is the mechanism by which it works. And both the RV and the LV need to be fluid responsive. CVP is not a good marker of fluid responsiveness. The importance of oxygen delivery in sepsis needs to be reassessed. It's unclear that whether this is actually the problem that's going on. And elevated lactate levels do not always indicate tissue hyperperfusion. There are other reasons why lactate can be elevated. And you have to be aware that fluid administration can paradoxically decrease organ perfusion. And so I've bolded this because this is important. When administering fluid, please monitor and document the response to that fluid. You gave a liter bolus, blood pressure went from 70 to 100. You gave a liter bolus, blood pressure went from 70 to like 50. Lactate went from 10 to 2. Lactate went from 10 to 50. Write this down. This needs to be like plastered all over the chart. I've made this red, capitalized, italic, and underlined. Do not continue to give fluid to fluid unresponsive patients. This is crucial because in this setting, you are not increasing perfusion and there is only harm being administered at this point. And so I really think that we should consider administering moderate amounts of fluid with early initiation of vasopressors. Again, 30 cc's per kg, see if they're fluid responsive. If they truly are fluid responsive, then consider giving them more fluid. If they are not, stop giving them fluid. And fluid administration in sepsis should be assessed like any other treatment. And we need randomized controlled trials with important endpoints: mortality, morbidity. Thank you.
Thanks, that was terrific. So you showed that hemoglobin administration transfusion doesn't help mortality. That's been in a lot of trials, including the ICU. So do you think the benefits of increasing oxygen are offset by any detriment in the volume? Like, why do you think the mortality doesn't change when you deliver more oxygen with more packed cells?
I think the main issue, and I was kind of trying to hint at this at the end, is I don't think sepsis is a problem with oxygen delivery. In the sense that we often assume that a patient is hypotensive with an elevated lactate, and we assume that it's a problem with oxygen delivery. And turns out there's no evidence to support that. And in fact, there's a lot of evidence to support that perfusion to organs during sepsis, at least in animal models, is actually increased. And so either, from a macro perfusion standpoint, the renal artery and all that stuff. So the question is there something else going on, that sepsis just kind of shuts down the organs and things don't work and also causes hemodynamic changes? Or is it a kind of microcirculatory problem where there's intra-organ shunting and so on, which is not responsive to increases in massive increases in oxygen delivery globally? So the fact that no trial in any way with the improvement in oxygen delivery has helped really makes me question, like, perhaps this is kind of a red herring in what we're chasing.
It's interesting that if you took a Washington manual from 1980, you'd come down exactly to your conclusions. So giving some fluid, not too much fluid, was the answer, 30 years ago. So we've kind of gotten back to where we started. And I participated in a center where we actually cranked up the cardiac output with dobutamine and had a higher incidence of AFib, VT, and MI. And so what's interesting is the idea of using beta blockers, which may in fact, help, improve, myocardial ischemia and other parameters. And I don't know if you think we should be doing that now.
Yeah, so I think, that also gets to Andy's point as well. The question of, is it, perhaps the increase in oxygen delivery itself that's causing harm, or is it because of the administration of our therapy that's causing the harm? And the interesting aspect of the dobutamine trial was that there was actually no increase in arrhythmias or anything like that. The patients just died of multi-organ failure. And so it's unclear whether increasing this oxygen delivery is harmful itself or it's because of the mechanisms by which we achieve them. You bring up beta blockers. This is sort of like the days of increasing cardiac output with patients with heart failure. And so, exercise tolerance predicts mortality in patients with heart failure. There was a trial where patients were given milrinone versus placebo. When you got milrinone, your exercise tolerance improved. That was, in the New England Journal. 2 years later, it was shown that oral milrinone actually increased mortality. And now we give beta blockers to heart failure, which is a crazy idea. The heart's not pumping. We're going to give something that decreases the heart rate. So I think we have to completely change the paradigm as to how we view sepsis and what the underlying issue actually is. Is it really the hemodynamic perturbations that are causing the patients to be this sick and to die, or is it something else? And how do we address that something else?
Great, thank you.
Thanks.